Govindan, I'm going to ask you to put down your squamous crystal ball and put up your immunotherapy crystal ball, and tell us where you think we're heading. You know, we've got. I see it as a choose your own adventure here. There's a lot of different possibilities. One is single agent in a PD-L1 restricted patient population. There's data with combination chemotherapy. There's combination strategies with other checkpoint inhibitors. There's certainly novel strategies in the second line. Can you talk a little bit about where you think we're heading? Maybe mention some of the data we have so far with chemo and what's on the horizon.
Sure. So first, I think we are in this for a long haul. This is not going to be a drive-by-night approach. This is going to be an entirely new era that's going to be with us for a long time. So I see there are two radically different approaches, and they may come together, they may complement each other. The first one is how can we optimally combine the inhibitory checkpoints as well as the agonistic elements. You know, for the immune system to act, there are inbuilt checkpoints that slow down the immune system activity. That's the CTLA4, PD-L1, PD-1 axis. But also the other things that are involved, like IDO1 inhibitors. And so these things are moving along very nicely in combination. So we're going to see combination studies in this setting. Of this, the important thing, immediate one, is this combination of the ipilimumab, nivolumab in the frontline setting of non-small cell lung cancer, the CheckMate 12 study. And that showed in the frontline setting, the combination actually produces some impressive response rates. And also the 1-year survival rate upwards of 70%, and the median progression-free survival upwards of 8 months. And I think we can build upon that, and it's reasonably well tolerated, not that hard to manage. The results may not be as impressive as what we see in melanoma, but certainly really gives hope that the blocking CTLA4 and the PD-L1 is PD-1, PD-L1 axis is an important one. In a very small subset in the CheckMate 12 study, if I'm not mistaken, of 12 or 13 patients who had a high level of PD-L1, above 50%, the response rate was a fantastic 70 or 80%, and more than 90% were alive a year later or so. So again, these are small numbers, but that brings up an issue that is PD-L1 expression maybe a better marker for a combined inhibition rather than for a single, nivolumab. So all these things will be fleshed out in the coming years. So that's right now we see it, and we're going to see a lot more in the coming years. There are second-line studies with a number of inhibitors, number of combinations. The IDO1 inhibitors are going on. And there are now the master protocols. The BMS has this fraction study where you have multiple different arms being replaced, and for the post-Nivo patients. So that's really going on. And yesterday in the developmental therapeutic section, I was very impressed with the early data from OX40 agonist along with tezolizumab. And the important thing is, you would worry, OX40, by the way, is upregulated after the T cells are engaged, and they also suppress the T regulatory cells. So it's a double whammy in a way, in a good sort of way. So you can actually make the T cells activated, and then you eliminate the repressive T cell population. You would think that the combination may produce toxicities, but it's extremely well tolerated with literally no grade 4 toxicities or recall. There were only 2 responses, but it's a very early study, and the fact that we can combine them gives us a hope. We can select them. So that's interesting, and the 4-1BB and all those things are going to be targeted. So that's one set of approach. The other set of approach, where it's moving forward very quickly in liquid malignancies, is those CAR therapies, these adaptive therapies. And in fact, there was even a randomized study from Steve Rosenberg group in melanoma. And so these adaptive therapies going on. And then along those lines, apart from CAR therapies, now we are able to sequence the tumors and find the new antigens and pick those new antigens, create this, take the patient's T cells, expand them in relation to the artificial peptides and infuse them. In fact, we have already treated our first several patients, and you can induce antibodies for more than 50% of the new epitopes. And then you have to take it forward with checkpoint inhibitors and combine them. So it's really moving along in these 2 kinds of directions. So it's really a fascinating approach.
I would piggyback. I mean, I've been impressed with the data that you mentioned. I've also been impressed, and I didn't think I would, with the unselected adding chemotherapy with PD-L1 drug up front, atezolizumab with carbopem. At least in data presented at World Lung, eliciting response rates in the 75% range, although a small number of patients. But I think the data is really compelling, and certainly there are competing strategies here. Very, as you mentioned with OX40, CAR T-cell approaches, very novel approaches that can be done here, and I think we're just at the beginning. Any thoughts from the global perspective, European perspective, where you think we're heading with these drugs? Is it?
We are waiting, I think, like US, the results of the phase 3 trial in first line. So I think that the majority of these drugs will come in first line. I don't know if combined with chemotherapy or alone or with CTLA-4 or whatever we want, but it's possible that a fraction of patients will be treated with this kind of drugs.
Yeah. Any other thoughts from the panelists where we're heading with this? I think we've covered a lot here. I'm certainly impressed with the combination data I saw yesterday with CTLA-4 in a PD-L1 positive patient population. Certainly the combination strategies with chemotherapy. I think it's going to take a lot of work, and I think it's going to make our jobs a lot more interesting, but a lot harder in a lot of ways to sort this data out.
But I think one fundamental difference now is that we're doing a lot more biology-based research, and I think that's what got us where we are today. We could have empirically, I guess, found who gefitinib worked in, but knowing there was a mutation there, and knowing what we do now about the immune system, I'll pick on the chemo. Giving chemo with the PD-L1 drug, is that the right thing to do? Well, not really. What seems to be the right way to do it is to figure out how chemo would modulate T-cell populations to best take advantage of the immune attack that you initiate by giving an anti-PD-L1 agent. So, I mean, that's where I think we got to go. And I think we just have to, remember, stay with the lady we brought to the dance here. It was biology that got us here. And we really need to pay attention to that and just stop kind of throwing things together because they were produced by the same company, for example. I mean, that's not necessarily the way to do it, but pay attention to the biology.
Yeah, I think there's also looking at these drugs in first line, and certainly there's data in the second line in combination with CTLA-4, a Trimi-Durva combination that looks good in second line. But I agree. I think our treatment decisions have to be predicated on biology. And I think we're moving that way. I think it makes our jobs a lot harder, a lot more interesting, but a lot more meaningful for us and our patients.